Good evening, dear colleagues. Assalamu alaikum wa rahmatullah. Welcome to MEOM Academy webinar meetings. And we hope that you will enjoy the meeting today about very important topics that are going to be presented by a very eminent young speakers, and it will be discussed by very eminent expert panelists, and we hope that you will enjoy it very well. Today I will do in another way because I will give the names, then I will ask everyone to give a brief about himself for the people that are listening to us. So the moderator of the sessions today, Dr. Mahmoud Salem. Dr. Mahmoud, if you want to give a few things about you.
What, myself?
Yeah.
Well, I have been doing orbit oculoplastic surgery for the last 30 years. I was a professor of ophthalmology in Jordan University of Science and Technology and in Jordan University as well. And I am president of MEOM, and I am a board member of the executive committee of MEOM. I am taking care of the oculoplastic orbit chapter. I have been working with MEOM now for the last 4 years. And thanks to our guardian, Dr. Muhammad Al-Amri, for his activity. What do you want to know more about me? I'm 73 years old.
I want to say Dr. Mahmoud Salem, he's a well-known figure in oculoplasty in the Middle East and worldwide. And he is my mentor. I am proud that I was learning from him when I was in the university, Jordan University, learning the medicine and taking the residency program. Dr. Mahmoud also, he is well known as an examiner in many different boards. Also, he's part of the Arab board. So he is doing a lot. So if you want to talk about Dr. Mahmoud, we will need hours and hours to give a talk about him. We are privileged and happy that Dr. Mahmoud is the moderating of these sessions and the leading of the expert panels in these sessions. Thank you, Dr. Mahmoud.
Thank you, Dr. Muhammad.
Our also expert, Dr. Jacob Pinnick from Denmark. I know him now for more than 5 years, around 5 years. We are together, and he was with us also before in one of the conference. And he can give us a little brief about himself, Dr. Jacob.
Good evening, everyone. This is Dr. Jacob from Denmark, Copenhagen, Denmark. I've been doing oculoplastics for the last 13 years, splitting my time between Denmark and the UAE. We used to live there, me and my family, back in 2017. Came back in 18. I've been going back and forth ever since for the last 8 years. Just started my own center here in Denmark as well. I'm very happy to be here, and thank you very much, Dr. Amri, for your kind invitation.
Thank you very much, Jacob. Thank you. Appreciate. We have also Dr. Khalid Abu Haliqa. Khalid, he is not with us now, but I will give a brief about him. Dr. Khalid also, he will-known figures in the UAE. He is an oculoplastic, and he is working now as the head of department of Dubai ophthalmic department in Dubai Hospital, and he was also working before in Mafraq Hospital, many hospital in UAE. And he is the vice president of Emirate Ophthalmic Society. Also, we are having Dr. Rituraj Hedge from India. Welcome, Dr. Rituraj. The mic for you, please.
Thank you. Yeah, hello. Can you hear me?
Yes.
Yes.
Yeah, I'm Dr. Raguraj Hegde from Bangalore, India. I work in a multi-specialty hospital, and I am doing oculoplastics for about last 12 years now in Bangalore. I work in I exclusively practice oculoplastics and orbit in Bangalore.
Thank you very much, Doctor. Thank you for being with us. Now we came to the co-chair of this session, Dr. Aziz. Dr. Aziz, if you can give a brief about you. Then you will just introduce the name of all speakers and they will brief about themselves. Please.
Thank you, Dr. Mohammed. I'm Dr. Aziz Bashir, and I am working as a consultant with here at night Al Shifa Trust Eye Hospital, Rawalpindi, Pakistan. And I'm currently the president of the MEOM Young Ophthalmologist Board. So we have four amazing speakers from different parts of the world. First of all, we have Dr. Angie El Sharif. She's an ophthalmology and oculoplasty consultant with more than 15 years experience in aesthetic eyelid and orbital surgeries. Also
Your voice.
Yeah, we miss your voice, Aziz. Hello. Oh, okay. Dr. Angie, you are with us?
Yes.
Can you hear me?
Yeah,
Yes,
yeah, Dr.
now.
Aziz, yeah, we lost you. Yeah.
Sorry, I got disconnected. So Dr. Angie is the co-founder of Cairo Oculoplasty Center and co-founder of Focus Eye Center. Then we have Dr. Cheris Sanchez Tanlapco. She is the founder of the Philippines Network of Young Ophthalmologists, and she is a consultant ophthalmic and oculoplasty surgeons from Philippines, and she is also the editor-in-chief of the Apao Vayo current issue of Apao Vayo newsletter. Then we have Dr. Michael O'Rourke. He is an oculoplasty surgeon from Ireland. And last but not the least, Dr. Kobra Jelangnolu. I'm sorry, Dr. Kobra, if I'm pronouncing
You
it
will
wrong,
mention.
but she's an associate professor of oculoplasty from Turkey and a well-known figure in the Young Ophthalmology Network of Turkey. So over to you, Dr. Mohammed, so we can continue with the webinar.
Okay, thank you very much, Dr. Aziz. Now we can lead the mic to Dr. Mahmoud, and he will give in front of you. We will start, I think, with Dr. Angie. It is in front of you, Dr. Mahmoud, if you want to.
Thank you, Dr. Muhammad. That was very good, well chosen actual subject. The thyroid orbitopathy is a multifaceted disease. It has several aspects clinically, and still there is a big dilemma about what excites the thing. We know that autoimmune disease, but we don't know how really it is excited in one person and not the other. And also, there is a lot of challenges about the management. So actually, what I have seen, there are 4 subjects or 4 presentations that really cover most of the topic about the thyroid orbitopathy. And we will be glad to see. Don't see really young ophthalmologists here, but they are actually very, very, very active and intelligent, actually oculoplastic surgeons that we are glad to have them.
Only because of the age, Dr. Mahmoud, but they
Okay,
are
I know the age.
They are very expert.
Comparable to me, يعني معلش okay, fine. Yes, we are now. Let us start, and we invite Dr. Angie El Sharif, and she will speak about thyroid eye disease and pathophysiology and risk factors and the clinical spectrum. That's very nice. Please share your slides.
Can you see it all? I'm sharing the
Yes,
slide.
I see that. I see that. Thank you, Doctor. Okay.
Thyroid eye disease is an inflammatory autoimmune disorder.
Can you make it in a slide share, please? It is not in a slide share until now.
Okay.
Okay. Yes. Yes.
Enlarge, yes.
Yes.
Wait.
Now.
Now slide share.
Yes.
Yes.
As we all know, thyroid eye disease is an inflammatory autoimmune disorder of the orbit and the most frequent thyroid manifestation of the gravis orbitopathy, but it may rarely occur in euthyroid and hypothyroid patients with chronic autoimmune thyroiditis. Regarding the pathophysiology of thyroid eye disease, it involves an autoimmune attack where autoantibodies target thyroid-stimulating hormone receptors and insulin-like growth factor on orbital fibroblast. This activates the orbital fibroblast, causing inflammation, immune cell infiltration with T and B cells, lymphocytes, and the release of cytokines, leading to extraocular muscle swelling, fat expansion, and connective tissue remodeling. The confined orbital space exacerbates swelling, causing proptosis, eye refraction, and potential vision loss from optic nerve compression. Regarding the key mechanism of this pathophysiology, let's go back. It starts with autoantibody activation, mostly in cases of Graves' disease. Autoantibodies like thyroid-stimulating hormone antibodies bind to thyroid-stimulating hormone and insulin growth factor 1 on orbital fibroblasts. This binding triggers a signaling cascade, activating orbital fibroblasts, which are the key effector cells. Activating these orbital fibroblasts releases inflammatory cytokines like interleukins 1, 6, and 17, and the chemokines like tumor necrosis factor alpha and gamma, and recruits immune cells like T and B cells, lymphocytes inside the orbit. Then, this activates tissue remodeling, where the orbital fibroblast goes through remodeling into adipogenesis process, where orbital fibroblast differentiates into adipocytes and increases the erythroorbital fat, or goes into myofibroblasts, and orbital fibroblast becomes scar-forming myofibroblasts, causing fibrosis and muscle restriction, and appears in lichen squint, and increases the hyaluronic acid production, and which is tissue swelling and expansion. So finally, goes through orbital compartment syndrome, where the bony orbit cannot expand, so swelling of the muscles and fat increases pressure, pushing the eyeball forward and compressing the optic nerve, leading to vision loss. Looking at this diagram, which shows that the pathophysiology of the thyroid orbitopathy is a complex story, where it starts with autoimmune response, which forms antibodies, thyroid hormone antibody and insulin growth factor 1 antibody, binding with the receptors on the orbital fibroblast. Also, the diagram shows step by step how we can go with treatment and each step. When orbital fibroblasts become activated, this initiates the release of cytokines, inflammatory cytokines, and also the recruitment of the T and B cells and lymphocytes inside the orbital tissues. These cytokines, in response, activates the remodeling of the orbital fibroblast, which is to increase the size of the adipocytes, adipogenesis, the formation of scar tissue and fibrous tissue in the form of myofibroblast, and the hyaluronic acid production, which increases the fluid inside the tissues and leads to swelling and preorbital edema. So the main cells involved in this pathogenesis is the orbital fibroblasts, which are the central effector cells, which are activated by autoantibodies leading to inflammation and tissue expansion. Also, the immune cells, T and B cells, lymphocytes, and infiltrates the orbit and including the inflammatory cycle. Also, the two receptors, which are the thyroid-stimulating hormone receptor and the insulin-like growth factor 1 receptor. Regarding the risk factors which can increase the severity of the disease, we have many risk factors. The most important are the major, which are modifiable risk factors. Smoking is a main significant risk factor, which can increase the severity of the disease and make the smokers are 7 to 8 times more susceptible to develop disease than other normal people. Also, smoking increases the oxidative stress and the free oxygen radicals, which also increase the severity of the disease. Another risk factor is the radioactive iodine therapy. When we use radioactive iodine therapy without the cover of steroids, this in cases with hyperthyroidism and Graves' disease, this acts as a risk factor for the formation of thyroid orbitopathy or the progression to thyroid orbitopathy, and increases the risk factor up to 15–24%. Thyroid dysfunction, the poor control of the thyroid hormones level, both either hyperthyroidism or hypothyroidism, is linked to higher risk of developing or worsening of the disease. It also was found that hypercholesteremia and high levels of the total and low density lipoproteins acts as a predictor of this progression. We have non-modifiable biological factors, which we cannot control, like the gender. It has been found that women are 5 times more likely to develop the condition more than men, but men are more susceptible to have more severe complication of the disease. Also, the age. The risk is higher in adults over 40 to 50 years. Older patients are also at a greater risk for more severe symptoms. Genetics plays a role. There has been found that some genes variations like HLA and CTLA4 and interleukin 23 are having these variations plays a role in the formation in the presence of the disease. Also, family history of thyroid or autoimmune disorder makes this person more susceptible to formation of the thyroid orbitopathy. Some studies suggest that African American and white population may have a higher risk compared to the Asian population. Other contributing factors: coexisting autoimmune disease like type 1 diabetes, vitiligo, myasthenia gravis, Addison's increases the overall risk. Stress, psychological stress can aggravate the disease by affecting immune system response. Pregnancy, the postpartum period is associated with a higher risk of new onset or worsening of the orbitopathy. Some metabolic deficiencies like selenium deficiency, vitamin D, and zinc deficiency have been found to increase the risk of the development of the disease. Regarding the clinical spectrum of the thyroid orbitopathy, we can differentiate them into a spectrum by severity and spectrum by the phase. According to the severity, we can classify the disease into mild, moderate, and sight-threatening. Mild, where it is only lid retraction, mild eyelid edema, dry eye symptoms, mild proptosis. Moderate to severe, where the marked proptosis, diplopia from ocular muscle involvement, and lid swelling, and conjunctival chemosis, exposure keratopathy. Sight-threatening, where we have a compression on the optic nerve and severe exposure keratopathy. Spectrum, according to disease activity, we have an active phase, which lasts up to 24 to 48 months. This is the inflammatory phase, where it responds to immune suppression drugs like steroids and biologics. Here, the patient is having only pain, redness, swelling, progressive changes. In active, we have a stable finding, restrictive myopathy. Surgical correction is the only pathway here. Finished. Thank you.
Thank you, Dr.
Thank you very
Angie.
much, Dr. Mahmoud.
That's very good. Really, I thought you are going to mention also something about the at least two variants of the optic neuropathy, which is one with a soft orbit and one with a hard orbit. I mean, tell us about about retrobulsion and how really you look at really how much really the muscles are affected. I mean, type 1, you know that the one with the soft orbit is fatty mainly, but muscles are not affected, and they tend to have very benign course as regard the optic nerve. While the one with the muscle involvement, they have the restriction all gazes almost, and very hard orbit retrobulsion, and they have high tendency of optic nerve compression.
Dr. Mahmoud, احنا ممكن can we do the I mean this as a discussion
معلش
at the end
okay,
of
later.
the session?
Fine.
Because we need to involve the others. Maybe they have some ideas.
Maybe. But otherwise, it was very comprehensive about the mechanism and the prognostic factors and about the risk factors with the disease. You did very well, Doctora. Thank you.
Thank you, Dr. Mahmoud.
Should we go on?
Yes, Doctor.
Okay, fine. The second presentation is Dr. Cobra Sayalano Glo, and sorry for the pronunciation, from Turkey, and she will speak about recognizing thyroid eye disease, clinical and imaging insights. Maybe you are the one who will tell us about the thing that I thought it was missed. Okay. Dr. Cobra, yes, the floor is yours. Please share your.
Thank you very much. Good evening, everyone. I'm Dr. Kübra Ceylanoğlu from Ankara City Hospital, Turkey. Today, I will talk about how to recognize thyroid eye disease using clinical findings and imaging insights. Thyroid eye disease is frequently under-recognized and early signs are often misdiagnosed. Early recognition of TED is critical because delayed diagnosis may result in fibrosis, persistent diplopia, exposure keratopathy, or even optic neuropathy and permanent vision loss. In clinical practice, although most patients are hyperthyroid at presentation, thyroid eye disease is not limited to hyperthyroidism. TED can also occur in athyroid and hypothyroid states. Therefore, a normal thyroid status does not exclude thyroid eye disease. Importantly, in about 80% of cases, TED develops within 18 months before or after the diagnosis of thyroid disease, but this timing is not absolute. Thyroid eye disease should be viewed as a spectrum with two clinical phases. We see two patients here. The first one has active disease and the second one has inactive disease. The active phase is characterized by signs of inflammation, including orbital muscle enlargement, conjunctival injection, periocular tissue swelling, and chemosis. In inactive phase, inflammatory signs are no longer present. Disease activity typically waxes and wanes and usually transitions to a stable inactive phase within 1 to 3 years. When we look at the diagnosis of thyroid eye disease, it's clinical and requires the presence of at least 2 of 3 domains: laboratory evidence, characteristic examination findings, and imaging features. This framework helps avoid both over and underdiagnosis, particularly in atypical presentations. In this presentation, I will focus on examination findings and radiologic features. This slide highlights the variability of clinical presentation in TEDs. Eyelid retraction is the most common finding, followed by exophthalmos, restrictive strabismus, soft tissue involvement, and optic neuropathy. I want to discuss each feature in more detail in the following slides. Let's begin eyelid retraction. Upper eyelid retraction is the earliest and most frequent sign. When I see lid retraction, I always think TED first. Here we see two patients here. The first one has mild upper eyelid retraction, and the second one has more pronounced upper eyelid retraction. Upper eyelid retraction can be bilateral or unilateral, and it results from sympathetic overactivity affecting Müller's muscle, increased levator palpebra superioris contraction, proptosis, and scarring between the lacrimal gland and levator muscle. Eyelid retraction causes incomplete eyelid closure, leading to dry eye, tearing, foreign body sensation, blurred vision, and eventually exposure keratopathy. This slide also demonstrates two classic eyelid signs seen in thyroid eye disease. The first one is Moncrief sign. This sign describes delayed descent of the upper eyelid during down gaze. We also say it's lid lag. We see here right lid lag here. Another one is Dalrymple sign. This sign refers to widening of the palpebral fissure with increased scleral show in primary gaze. Another common clinical finding is exophthalmos. It's the second most common sign of thyroid eye disease and is usually bilateral. It results from inflammatory enlargement of the extraocular muscles and orbital fats. We also observe soft tissue involvements, which manifest as chemosis, conjunctival hyperemia, particularly at the rectus muscle insertions, and eyelid edema. Overall, this image demonstrates a typical patient with thyroid eye disease, showing exophthalmos, eyelid edema, lateral flare, increased scleral show, thickened brow, upper and lower eyelid retraction, and conjunctival redness. Restrictive strabismus is another important clinical presentation in TEDs. Ocular motility is initially affected by inflammatory edema and later by fibrosis. Symptoms include diplopia and difficulty in certain gaze positions. The inferior rectus muscle is most commonly involved in TEDs. In this patient, we see right hypotropia. It's observed due to involvement of the right inferior rectus muscle. She has persistent diplopia. Beyond the visible signs of thyroid eye disease, there is a rare but potentially blinding complication, dysthyroid optic neuropathy. Luckily, it occurs in approximately 5 to 8% of patients with TEDs. It results from optic nerve compression and increased orbital pressure. It's a serious complication. A multidisciplinary approach is required. Importantly, there is no gold standard test for this thyroid optic neuropathy. Diagnosis relies on a combination of clinical findings, which includes decreased visual acuity, afferent pupillary defect, but sometimes we can see afferent pupillary defect because this thyroid optic neuropathy is often seen bilaterally, and we can see color vision impairments. It's very important sign, and we can see optic nerve head changes, but we should be aware it can be normal in about 50 to 80% of patients, and we can see visual field defects, especially inferior scotoma. The presence of 2 or more of these features strongly supports the diagnosis. We need to be aware of this in all TED patients. Another important sign is exposure keratopathy. It's a secondary complication, actually. It's caused by lag of thalamus and proptosis. It increases the risk of corneal ulceration and infection. In light of all these findings, we assess the patients according to disease activity and severity. We use clinical activity score. It helps to differentiate active from inactive disease. This scoring system includes pain, spontaneous retrobulbar pain, pain on attempt upward or downward gaze, redness of eyelids, redness of conjunctiva, swelling of caruncle or pilica, swelling of eyelids, and swelling of conjunctiva. A score of 3 or more indicates active inflammation. This will be discussed in the treatment section. We also categorize patients into mild, moderate, and severe disease based on all of the clinical findings, which directly guide treatment decisions. In mild disease, you can see here a mild disease. Patients present with mild upper eyelid retraction, mild soft tissue involvement, and exophthalmos, mild exophthalmos under 3 mm. Moderate disease is characterized by eyelid retraction 2 mm and more, moderate or severe soft tissue involvement. The presence of optic neuropathy or corneal exposure indicates severe sight-threatening disease requiring urgent treatments. In the second part of my presentation, I will focus on imaging insights in thyroid eye disease. Actually, imaging is not required for every patient, but it becomes essentially specific clinical situations. Imaging helps us confirm the diagnosis, assess disease activity, identify vision-threatening complications, especially optic nerve compression, and helps to surgical planning. We use CT and MRI for imaging. CT typically shows enlargement of the extraocular muscle bellies. You can see this in this image with tendon sparing, a hallmark feature of thyroid eye disease. And this pattern helps differentiate TED from other causes of orbital myositis. CT also shows proptosis due to increased intraorbital contents. It provides excellent visualization of bony anatomy, and it's preferred before decompression surgery. Another important CT finding is apical crowding. Apical crowding on CT is a key imaging finding suggestive of this thyroid optic neuropathy. We can see here compression of the optic nerve by thickened extraocular muscles at the orbital apex. We call it apical crowding. When we look at the MRI findings, MRI is better suited than CT for the evaluation of soft tissue structures and evaluation of disease activity. On T2 stir hyperintensity of muscles indicates active inflammation. We can see here active disease. And also, we can evaluate orbital soft tissue and fat inflammation and optic nerve signal changes in severe cases. Eventually, CT and MRI are complementary. The choice of imaging modality depends on the clinical question being addressed. We prefer CT to evaluate bony anatomy, assess apical crowding or planar orbital decompression surgery. We prefer MRI to assess disease activity, evaluate soft tissue involvement, or to differentiate active from fibrotic disease. In summary, thyroid eye disease as a heterogeneous disease, early recognition, careful clinical assessments, and appropriate imaging are key to preventing vision loss. Thank you for your attention. I wish everyone a happy new year.
Well, thank you, Doctor. It was very comprehensive, clear for me, and I hope for others. I wish that we can really have some questions now, discussion, or panelists can really, because they are the first two presentation are different from the others. Now we are really about its clinical picture and about the mechanism of the disease, and they are different from treatment, so that we don't lose the track and still we remember about the things. I can call really any one of the panelists to comment on these two topics. Dr. Beniki?
Yes.
Yes. What have you any comment or question or you would like to share with us?
No, not right now.
Okay, fine. خلينا let's see. Dr.
Rituraj.
Aziz.
Dr. Aziz, he is vitreoretinal. I think we will go to Rituraj.
Uh-huh.
Oh, no. Yeah. I think basically the cytokines and the intermediary inflammatory cytokines that are there, the identification is actually now
Up.
the identification of these cytokines have actually given way to like targeted therapies with thyroid eye disease. So a lot of research is going on, and we have a few targeted immunotherapies like trastuzumab that is already in the market, but it's not available in all countries
Actually,
as yet.
we will hear more about it in the third presentation. Third presentation will talk about the medical treatment of the thyroid eye disease, and the fourth presentation about the surgical modalities and so forth. So actually, we are concentrating about the clinical picture and how would they diagnose the condition and so forth. It occurred to my mind, you didn't mention, Doctor, about the retropulsion test, which is very simple test. When you ask the patient to look down and try to do with your finger and feel how much is hard the orbit. Differentiate between the soft orbit, which is only fat, and even you can do fatty decompression, and you don't have to do body decompression. And they are very common patients. They come even for aesthetic. They want to have just aesthetic decompression. In comparison to the other orbit, which is very hard orbit, and when you do an MRI, it's all muscle thickened and very little fat. And sometimes they have even taut orbital septum with minimal amount of proptosis, but still very hard retropulsion. I call it, this is a nasty orbit. And these are the one who are amenable for optic nerve compression. these are actually, I call it concealed exophthalmos, concealed exophthalmos. You haven't mentioned that dose, which is, I mean, they constitute a significant number. I mean, like 10% of the cases, which they need very quick and urgent orbital decompression. معانا الدكتور خالد لسه خالد أبو حليقة.
لا خالد ممكن يدخل في الجزء الأخير ببلغ
الجزء
الجزء
الأخير.
الأخير.
السلام عليكم، أنا قاعد أدخل والله يعني.
هاي
دكتور
كويس.
خالد هاي دخل ما شاء الله. أوكي.
طيب ماشي. أهلين. How are you دكتور خالد?
Very good, very good.
You
How
are
are you
welcome.
doing?
Okay, fine. We were discussing the first two case, I mean, presentation, and the presentation were about the mechanism of and the pathogenesis of the thyroid orbitopathy, and the other one is about the clinical picture and the diagnosis.
Yes, doctor.
Okay,
I've listened to some of
aspects.
it. Yes,
Fine.
Yeah.
Yeah,
I agree with you totally about the retropulsion test. That's a very important test, especially in the East. In the Asian population, some of them won't show this obvious proptosis, and they can have a hidden aspect of it.
Yes.
Can I ask a question, Dr. Mahmoud, for you and all the panelists?
Yes, please.
We know that thyroid disease is, we can call it a systemic disease, if you want. It's not affecting only the eye.
Yes, it is Graves'
Okay,
disease.
so it is an autoimmune disease. So, and it have a part that affecting the eye. So then we, in the first one, in the first presentation, and maybe in the second, they are talking about the what are the role of the congenital or not congenital. I mean, if there is any link between this disease and chromosomal genes. How is this really affecting the? I mean, it's play a role in the thyroid disease.
This is mysterious. I mean, this is spot actually is mysterious still now. We don't know. There are, well, many patients have no thyroid disease by itself, but they have thyroid orbitopathy. And not every patient with thyroid disease, I mean, like, should have thyroid orbitopathy. I mean, they are not linked, thyroid disease and the thyroid orbitopathy, in really a causal relationship.
I think Dr. NG, she mentioned something about this one. If you can hear from her opinion, because I saw in the slide that she mentioned something about the gene. You are mute, Dr. NG.
Please unmute yourself, Dr. NG.
Okay, going back to the literature, I found some papers say that there's a connection between some gene variant like HLA4 and some variation in the gene can be combined with the thyroid orbitopathy, but not something sure now for gene therapy. There is no, to my knowledge, there is no gene therapy now have been approved for these cases, or this they only found them by chance. That's not gene therapy for these cases. But so
we are not talking about gene therapy. We are talking about gene cause.
Gene cause. I am mentioning that some literatures mention that there are gene causes. They found some cases which had HLA4 variants as having thyroid orbitopathy, having the same gene. So they say that these genes can be a risk factor, this gene variant, a risk factor, but not till now, there is nothing sure about this and no therapy for this.
The science is only about association, no causation with the genes that you mentioned. But it's just an association, no proof of causation yet anyway. We'll see in the future if we can get but I agree, it's a mystery until now. There's a lot we don't know about this disease.
Okay, Dr. Khaled and others, how do you go? I mean, yeah, sorry. Who wants something to talk?
Yeah, I just want to add that it is sometimes difficult to tell the patients also to explain the disease to the patient. So what I often say is that both your thyroid and your eye are the victims of the same disease. It's a systemic disease which is affecting both your thyroid as well as your uh, eye as well, because of the common antibodies. So it's sometimes very difficult to explain because patient says that I don't have thyroid, I don't have any thyroid problems, but I have orbitopathy, and because in cases of thyroid eye disease, it's sometimes very difficult to explain the patient that why are you having thyroid eye disease.
Yes.
Are we treating when we are going to come to the treatment? But now, for example, when we are facing a patient with thyroid eye disease, and we want to tell the patient or the family that he is having some sort mild, moderate, then he will ask, there is anything to prevent or to get more to reach the last point? Is there something, or just we are waiting to what will happen, then we will go to interfere accordingly?
Of course, the smoking is a big factor. That is something that we can control. If the patient is smoking, we can always ask them to. This is something that is controlled. So we have to explain to the patient that smoking is not what has caused the thyroid eye disease, but smoking is a definite risk factor. Smokers have a worse course of the disease. So controlling smoking definitely helps with the management of the disease. No matter how we treat it, if the patient continues to smoke, he will have a worse course of the disease.
Very important to note in that regard, passive smoking and even scent smoking, like bukhur, that also contribute. So they don't need to be active smokers, but they are in an environment of smoking.
Right. Agreed.
Is there, for example, when we are facing a case of thyroid disease, so how we can organize our investigations? What we shall do? What are, I mean, this one, Dr. Cobra, she mentioned some of this, but how we can go and tell what are the most important things that we can do to continue in diagnosis and other.
clinical طبعا she mentioned that
the clinical
our
presentation
clinical picture
one of
is the most very important.
Okay, so what we are using CT scan, MRI, just to what? To see how is far effect or only
the MRI with the MRI with contrast showing a fluid in the muscle might be an indication of activity as well. That can sometimes help, but the clinical picture is what really should be pointed out: clinical activity score and so on. That's how we should be approaching it in a clinical way. The test, like the trap test, the antibodies, that's are important. There is an association. It's not exactly also linear, but it's important to test it as well.
What I do is that I do CT scan essentially, not MRI. CT scan essentially, and I do it just before surgery. It's not necessary that you do it for diagnosis. It doesn't add any information. Clinically, you have good hormonal assays, you have good thyroid antibodies in the patient's blood. I mean, this is very important. But I mean, only blood tests or a clinical picture. That's what diagnose the thing. CT scan or any neuroimaging just before surgery. Once you want to do interference or whatever, it's not necessary that you do that for everybody.
Yeah, absolutely. For
Dr.
any pre-surgery, I agree. The CT would be superior for any patient prior to surgery. That's essential. Okay. The MRI is really done, in my opinion, if we are going to use biologics and things like that. But that's another talk. Maybe we'll talk about it in the third presentation.
A few cases maybe you need. You, Dr. Jacob?
I think maybe we as experts in this field are getting a little bit ahead of ourselves. I think Dr. Cooper said it very well, that this condition is quite undiagnosed and underdiagnosed. So what I would tell my colleagues here in Denmark, at least, our system is probably a little bit different from what you have elsewhere in the world. But we have a big population of sort of general ophthalmologists. So I would try to emphasize, for starters, at least all the eyelid signs, all the small signs there that should raise the suspicion of maybe this could be a thyroid eye disease patient. They're quite often there with the temporal flare, the eyelid retraction, all these things that should lead these patients to someone like us who could take care, do the CT or do all the blood work, all the things that needs to be done. But the clinical diagnosis is probably what the message that really has to come across with this webinar for all the younger colleagues out there who doesn't see these conditions all the time.
Thank you. Thank you. I think we can proceed with the other two presentations so that really we have some time for discussion also. The third presentation is about the active TED, whether we need steroid, immunotherapy, and biologic. And Dr. Cherez Sanchez Talanpeco from Philippines, isn't it? Yes? Can you unmute yourself?
She's unmute, but we cannot hear you.
Can you hear me now?
Yes.
Okay. Okay. Now.
All right. All right. Perfect. Okay. Let me see this. Okay. All right. Okay. So yeah, I think you can see my slides now. So I have 10 minutes. So good morning from the Philippines. I would like to thank Dr. Aziz for this wonderful opportunity to be part of this meeting. It's such an honor to be on the same platform with all of you. I was tasked to discuss thyroid eye disease, steroids, and emerging therapy. And then this is the outline of my lecture. So I'll bet none of us enjoy managing patients with thyroid eye disease. I've been on this career maybe 8 to 10 years now, and it really pains to see like thyroid eye patients come to my clinic. So we're done with all the definitions of thyroid eye disease, but the thing that strikes me most about this is about the physical, emotional, psychological, and socioeconomic burden it brings not just to our patients, but to the ophthalmologists as well, especially because I come from a third world country. So the disease process of TED usually follows the trajectory of the Rundle's curve. So the first phase is the active phase that is likened to a house on fire when all the signs of inflammation are obvious. And then the second stage is when the fire calms down, but then the permanent damage is already there. As ophthalmologists, we want to be in action during the active phase to prevent the permanent damage. I know this has been discussed earlier, but to be aggressive in thyroid eye disease, we have to know the pathophysiology of the disease because our management is really dependent on the pathophysiology. So science, the development of treatment is dependent on the pathophysiology of this disease. So for the viewers who weren't able to listen to Dr. NG earlier, just remember that the orbital fibroblast is in the center of thyroid eye disease. So the orbital fibroblast is just like a stem cell. And then with the abnormalities in the antibodies that are produced in thyroid eye disease, the IGF-1 and the TSH receptors are abnormally activated during thyroid eye disease, such that the orbital fibroblasts get angry and then they develop into myofibroblasts and adipocytes out of control. So so the inflammation explodes, and then that results to all the signs and symptoms of thyroid eye disease, such that the management is really dependent on controlling first the inflammation, the signs of inflammation, and then right now, the management is dependent on managing the root of the cause. So how do we help our patients? As I was tasked to take on an overview of the medical management of TED, I would like to share the 2022 consensus statement by the American Thyroid Association and the European Thyroid Association in the management of thyroid eye disease. In mild active TED, management is supportive with selenium supplementation. And if necessary, oral glucocorticosteroids are also acceptable. But in moderate to severe TED, the ETA and the ATA prefer the use of intravenous glucocorticoids. So from oral, we move to intravenous glucocorticoids. And if available, the biologic agent teprotumumab. But in case this is not available, other biologic agents that may be considered are rituximab and tocilizumab. But in sight-threatening TED, the preferred therapy according to the ETA and the ATA would be IV glucocorticosteroids. So based on this statement, the main medications we need to know about in active TED are steroids and the monoclonal antibodies teprotumumab, rituximab, and tocilizumab, and a few other medications. So steroids. Steroids reduce autoimmune attack by suppressing inflammatory cells and blocking pro-inflammatory signals, thereby decreasing swelling, pain, and pressure. It is most impactful during the active phase, especially when patients present with predominantly inflammatory signs and symptoms. So in mild active TED, you may or you may not give steroids. And again, based on recent consensus, it is acceptable to give oral corticosteroids. So in this side of the world, I usually give it prednisone at 1 milligram per kilogram per day with, of course, a proton pump inhibitor and then gradual tapering. I used to be scared of giving IV methylprednisolone until I really internalized the European Group of Graves Ophthalmopathy protocol. So in moderate to severe active TED, it is a must for us to give IV methylprednisolone. UGOGO suggests 500 milligram per week for 6 weeks, then 250 milligram per week for 6 weeks IV infusions. But personally, I follow the NUHS or the Singaporean protocol at 1 gram per day of methylprednisolone for 3 days and then 1 gram monthly for 5 months. Of course, I do it with an endocrinologist on board. And prior to the initiation of the treatment, I do baseline laboratory workup because despite steroids being wonder drugs, they do not come without side effects, especially if given high dose. So although not endorsed yet by UGOGO or the ETA and the ATA, Dr. Yuji Yamana from Japan published this paper in 2024 suggesting the use of steroid injections in active TED. So he used 1 ml of triamcinolone 40 milligram preparation injected retroceptally using 1/2 gauge needle, 1/2 gauge 27 needle. So in his cohort of patients, the clinical activity score decreased by 2 and the MRD1 decreased by about 0.8 millimeters. So no adverse effects were noted in his cohort. I personally have done this in, I think, 2 patients. No side effects. After 2 weeks, the redness subsided. And I think I am definitely going to try this on more patients, and this is a promising therapeutic avenue for active TED. After steroids, let us talk about monoclonal antibodies. So monoclonal antibodies are lab-created proteins designed to mimic the immune system's ability to fight harmful agents targeting one specific antigen or cell. We are now trying to block specific pathways that lead to the signs and symptoms and the mechanisms that promote TED. We have monoclonal antibodies that target the TSH and the IGF-1 receptors. So we have teprotumumab, and then we have monoclonal antibodies against cytokines like tocilizumab. And then we have monoclonal antibodies that target B lymphocyte immunomodulation, such as rituximab. First on the list is teprotumumab. So this is the first and only US FDA approved medication for TED. It works as a fully human monoclonal IgG antibody against IGF-1 receptor. In a review of 2 multi-center double-masked placebo-controlled trials on TEP in moderate to severe TED, TEP was associated with rapid and clinically significant reduction in proptosis, tissue inflammation, and diplopia. So that's why this is highly recommended by the ATA and the ETA consensus statement. So teprotumumab must probably be good, but it is not without its own set of side effects. But I think the problem with teprotumumab is not really just the side effects. I think the problem is really its cost and unavailability. So right now, I think it's just definitely it's not available in this part of my world in Southeast Asia. And the internet states that a single vial costs a whopping 14,000 US dollars. No? And we give it per kilogram, no? Per body weight. So there's a big problem in there. So the second monoclonal antibody is rituximab. So it is still off-label for TED. Its mechanism of action is that it targets CD20 in activated B cells, and it impairs new antibody production and B cell mediated helper function. Unfortunately, the only 2 studies available on rituximab have conflicting results because one study showed benefit and the other study showed no benefit. The last monoclonal antibody I would like to discuss for TED is tocilizumab. So its mechanism of action is on the that it is an interleukin-6 receptor blocker. So the reports on its use in TED are confined to less than 100 patients as of date. Tocilizumab inactivates disease and it really improved proptosis and diplopia in this set of cohort. So finally, let's discuss the other medications. So mycophenolate is an immunosuppressive medication that targets both B and T lymphocytes. Its published experience in TED is limited to two RCTs, 1 non-RCT, and 1 retrospective report. So UGOGO recommends its use with IV methylprednisolone as first line of therapy for TED. However, the European Thyroid Association and the American Thyroid Association consensus state that there is not sufficient evidence for the use of mycophenolate. And then finally, selenium. Selenium is an essential trace element and a powerful antioxidant in managing stress and inflammation, which are central in the development of active thyroid eye disease. So UGOGO recommends 200 micrograms once daily for 6 months. However, there are recent studies that says that it may not improve mild to moderate TED in selenium-sufficient regions at 6 months. So I think in Pakistan, it is not, I think that you are selenium sufficient. So maybe selenium supplementation may not be recommended. But for me, I personally give it anyway for my patients. So in summary, the management of TED is based on the details of its pathophysiology. Corticosteroids remain the first choice, most widely available and most affordable first-line therapy for TED. Teprotumumab is the only US FDA-approved medication for TED and is a preferred first-line therapy when available. Mycophenolate and selenium are promising adjuncts in active TED management. And TED management is a challenge, but science keeps moving forward, so we look forward to more developments in the future. Thank you very much for your kind attention.
Thank you, Doctor. That was very almost comprehensive medical management of thyroid eye disease, and you really outlined that in a very elegant way. I mean, the floor is open for discussion and any question.
I have a question,
Yes,
Doctor.
please.
Do you in the Philippines test levels of selenium in your patient?
Actually, no. We don't. That's not done routinely, especially because I practice 4 hours north of Manila, so we don't really test the selenium levels of our patients.
Do you
I am
know?
aware of.
Yeah. Go ahead.
Yeah, I am aware of selenium toxicity, but I think there are really not much reports on it. So we just give it um we just give it to our patients.
All right. And do you know if the intra orbital injection of triamcinolone lasts for how long, and do you need to repeat it from what you looked at?
Oh, yeah. So for that study, I think they can repeat it up to 4 times. Yeah. I have colleagues who have been doing it for, I think, 1 to 2 years now, and they think that the results are quite promising. For me personally, I don't have that much patience. I think I've done it only on two. So far, I think it's been really promising for them, and I didn't have to repeat it on my patients.
Yeah, what I know is that really it's effective in selenium deficiency. I mean, usually what I do selenium level, and we can do it here in Jordan. And if selenium level is really deficient, we give selenium. Otherwise, it's not necessary. I don't think it is. It's why just to give patient selenium while he is have selenium if
Sufficient.
efficient or whatever. Okay.
I
Okay.
I'd like to mention a little bit about the teprotumumab.
Okay.
We have registered teprotumumab in the United Arab Emirates about a year ago. First patient was treated in February this year in the UAE after registration. I personally treated about 6 patients to 7 patients now already. And it is expensive medication. I totally agree on that point. Accessibility is an issue. But it is the only FDA approved, as was mentioned, and the science kind of tweaks in towards its benefits in comparison to the other monoclonal therapies available. And I'm happy to discuss my impression about it.
Very nice. Okay. Dr. Jacob, do you have any comment about what you have heard? Can you unmute yourself? Unmute yourself.
You are muted, Dr. Jacob. Can you unmute, please?
Okay.
Oh,
Well,
yes.
I think here in Denmark we have a small population, so these treatments are typically done in close collaboration between ophthalmologists and endocrinologists. From what I know and understand, teprotumumab is not registered in Denmark at this point, so this would be IV steroids typically, as well as surgery eventually once we are in the quiescent phase. So the treatments are typically monitored by the endocrinologists because of the high doses of steroids. Yeah.
I know Dr. Khalid Abu Haliqa has experience with teprotumumab. They have, or they are using it in AOE. Yes, you can really tell us more about it.
Yeah, so it's usually when we start, we give like about 10 milligram per kilogram. So that ends up in most of the population about 70 to 80 kilogram weight of 3 vials, giving it on 3 vials on the first kind of time, which is 10 milligram, and then moving to the second cycle, which is 3 weeks later, 20 milligram per kilogram, and doing 7 cycles of that. So altogether 8 cycles. Every 3 weeks, 1 cycle. It's an IV infusion that lasts for about 60 to 90 minutes each time. Patient come as an outpatient infusion and go home. The effects have in what I've seen have been significant from the proptosis point of view and from the clinical activity score, as well as the strabismus condition, which aligns with the what the indication for it in the ETA ATA consensus. Also from the optics trial that was done as well about the teprotumumab. The issue with it, the safety issue, is considerable, especially for the issues with hyperglycemia and the issue with the inflammatory bowel disease patients, as well, of course, with the audiology issue, where about 9% have some audiological issues like hearing. I wouldn't say hearing impairment, but they can have a hearing fullness and tinnitus, and only 1 to 2% get some hearing impairment. But they can be permanent as per studies. I have not seen a permanent hearing impairment in my patients yet, alhamdulillah, but it is something I monitor very closely. And even before I start, I have a full discussion with the patients about the side effects and the consequences of those side effects, so that they have an informed consent for doing the treatment. In my opinion, the studies about teprotumumab is still live studies. I mean, in real patients, it still needs more numbers, especially in different populations. There are trials that was done, the optics trials and so on. They were done in a certain population, North American population, which maybe act differently from other population, either in the Middle East or in the Far East, with the thyroid eye disease natural history. So it's very important to get as much as possible knowledge about the patients in real life to say, on the long term, does this medication, is it worthwhile? Is it cost effective? And also, how can we use it? Yes, it's been used to moderate to severe cases with active disease, clinical activity score of 4 or more, but it's not proven or disproven to be used in other cases. So I've seen it being used in cases where the actual is a little bit chronic cases, not fully active cases. So it's kind of it's an important kind of situation. Yeah.
Fine. Would you like me to comment on the surgical size of it? I mean, at least in Jordan, we don't have teprotumumab, we have to excel in doing orbital decompression. But this is what I am doing actually. It's almost every week. But we have cases actually that comes from I mean, not only from Jordan, but also from nearby countries for this. Actually, we need the orbital decompression for actually asymmetrical proptosis, for example, asymmetrical exophthalmos, which is rather common, or when you have before muscle surgery, if the patient have a lot of diplopia, and you want to do muscle surgery, you have to do orbital decompression before. And also, if really you want to reduce the orbital intraorbital pressure and safeguard against orbital optic nerve compression. These are the functional causes. But many of my cases also for cosmesis, they come after they have been stable for some time and they are all right, but they don't accept themselves as having exophthalmos. And we do that. Of course, when you do the orbitotomy, I mean, like whether you do, I do 3 walls most of the times, lateral wall, floor, and the medial wall, if there is optic nerve compression. And the whole essence of it is not only you remove the bone, you should open the periorbita, the periosteum. Very good opening, and you release the fat if it's possible. Okay, and it's very important that you open the periorbita. And this is the whole essence of it. Actually, the orbital decompression has been practiced, I mean, historically by ENT surgeon, by neurosurgery, by maxillofacial surgeries, people, but they have really a lot of complication. But doing orbital decompression with the oculoplastic surgeon, there is minimum amount of complications, minimal amount of damage to the optic nerve, minimal amount of really CSF leak or whatever. All these are kind of historical, let us say, complication that we don't see it because you are doing it from within, not from without. Of course, we have read about the orbital decompression from the Caldwell lock, whatever, or from the skull or whatever by the neurosurgeon. But now we are doing it properly, and we are getting very, very good results with it. Actually, traditionally, they say orbital decompression first, then muscle surgery, then eyelid surgery, whether it is eyelid retraction and so forth, 6 months apart. But I don't adhere to this. I am doing combined now oculoplastic procedure with the orbital decompression. Not always I do this, and I have showed this in several cases, and I have done many cases like this, and I presented this in several meetings as well. And I know that some people have published combined orbital surgery, I mean orbital decompression with muscle surgery and eyelid retraction repair as well. I would like to hear Dr. Jacob Benecki and Dr. Hedge about their experience with the orbital decompression. Please.
Shall I go? I can go first. Well, Denmark is quite subspecialized, so we do the oculoplastic surgeons. They do the orbital decompressions, typically like you do, doctor, 3 walls, and then you move to muscle surgery, cures your business, and eventually, finally, you do whatever cosmetic eyelid procedures are necessary. And we have strabismus surgeons primarily doing the correction of the muscle surgery. So this is not typically a part of oculoplasty in Denmark anyway. So quite subspecialized. But that's the way. That's the sequence to do it: the orbital decompression, the muscle surgery, and then cosmesis. So a little bit different.
Are you doing the medial wall yourself, or you ask the ENT surgeon to do it, the medial wall?
Pardon? Sorry?
Are you doing the medial wall orbital decompression yourself,
yes,
or you ask the ENT surgeon to do it endonasal?
The ophthalmologists do that. Yeah, we do that.
Ophthalmologists do that. The transcaruncular approach?
I'm not sure. I don't do them myself though, but my colleagues, they do.
See.
So yeah.
I see. Okay, fine. What about Dr. H?
Yeah, in our part of the world, we don't do surgery in mostly the surgeries are done in the inactive stage of the disease.
Of course.
We don't have that. The numbers are not that high, and we have something called a silent thyroid eye disease in India, where almost about 50% of our thyroid patients are inactive. They present at the inactive stage. So the active stage is the subclinical. So they come with some deficits like eyelid retraction or a proptosis. They're mainly concerned about the cosmetic part of the thyroid orbitopathy. So most of the orbital decompressions that we do are for cosmetic in nature.
Okay, for cosmesis. Okay.
Cosmesis. So what we have seen is that in many of these, when we do the scanning, we mostly do the CT scanning because we want to see the walls of the orbit and plan for surgery. The ones which have muscle dominant disease respond better to decompression than the fat dominant disease, because the fat dominant, when they're inflamed uh, and the size of the fat globules increase, even when we do a fat decompression, and I mean, even when we do the bony decompression and we do a balanced decompression on both sides, the fat doesn't flow like a natural fat flows in a normal orbit. So it is mostly fibrous fat. So even if you do a bony wall decompression, the fat doesn't flow into the extra spaces that you have created. So we see that in our patients, cohorts which have muscle dominant disease, those have respond better to decompression than the ones with fat dominant disease.
Dr. Abu Haliqa بتحب is there?
Dr. Khalid already he left. He have something as you know. But we have, I think, if you don't mind, Dr. Mahmoud, we have very eminent people. They are attending here. Dr. Usama Ababna, Dr. Hisham Nizar. If anyone to share his experience,
or question,
we are going to happy to open for him the mic. I don't know if someone can raise the hand and participate with us. So we will open for him. And till we there is also a question, Dr. Mahmoud, from one of the attendees is asking if the patient has a mild unilateral exophthalmos lead lag with euthyroid, how can we manage?
Okay, fine. Would you like me to answer this, or somebody will answer?
Any one of the. I mean, this is all you, Dr. Jacob, or any others, Doctor. They are speakers, also they can share also their experience, whatever.
Okay, about mild exophthalmos.
Okay.
And that's for cosmesis then.
Yeah,
yes, you can offer him
orbital
euthyroid. With the lead lag. I mean, lead lag. Even euthyroid. I mean, like the orbital, thyroid eye disease. We are managing it in separate from the thyroid disease itself. Thyroid disease is managed by the endocrinologist. Okay, but the thyroid eye disease is managed by the oculoplastic, and they don't go hand in hand. And if the patient is euthyroid, he's fine, established now for the 1 year or two, whatever, anything. But after six months, you can do surgery. Okay, very common. These patients, they come and they want to have their eye, whatever, eyelid retracted to be corrected, or exophthalmos to be better. I mean, people don't, especially females, don't accept themselves. So bizarre nowadays. I mean, people are doing refractive surgery to get rid of glasses. For what about if they want to see themselves and take selfies and so forth? Yes, we do that orbital decompression, fatty decompression at this stage, and eyelid retraction repair. And this is easy procedure. It's not complicated, and good results. Good results with it.
Okay, is there any comment
well,
from any speakers?
yes,
Anyone of those speakers, Dr. Kubra, Dr. Cheris, or Dr. Ingi? Anyone want to say something? Please unmute
So,
yourself.
yeah, I'm very conservative with my patients. Um, I think we have to know whether it is really if the proptosis is mainly caused by muscle or by fat. Personally, I have been a fan of fat decompression. If it's mild proptosis, then it's probably fat. No, there. And then if the proptosis isn't so bad, sometimes I just do very conservative, like a minor surgery, do a lateral tarsorrhaphy for the patient. So just to uh, just to offset the appearance of the patient. And then sometimes I also do Botox, botulinum toxin injection on my patients for the lid retraction.
oh, okay, botulinum toxin in the first stage. I mean, like when there is a
Oh, yeah.
kind
Usually
of
it's for the
yes.
But
yeah,
it's
if
very
it's
difficult to titrate, right? It's very difficult to titrate the
yes,
dosage
very, very,
for.
very. Yeah, I just put some like really, really a small amount. Yeah. Because it's better to like do it little by little rather than like you cause ptosis, like a big amount of ptosis.
So
When
in some patient with subtle retraction, I use hyaluronic acid fillers to lift to put some weight into the onto the tarsus. So it will be at the sublevator space. So that will add weight to the on top of the tarsus, which pushes it down. And as time goes, it stretches the levator muscles as well. So it may even we may not even need to do it a second time. Even if the HA fillers gets absorbed within a year, it maybe the lid usually sometimes stays at the same position.
well, what yeah, I mean, our eyelid retraction, if it is really acute or early stage, and this is you suspect there is sympathetic overtone, yes, you give Botox or whatever. I don't think يعني gold weight and so forth is the right thing to do. But what I do, blepharotomy, graded blepharotomy, it works very well because many of these chronic, they have fibrotic elevator and fibrosis, and you have to cut it actually graded. I mean, and it gives very good results. This is what I do at least.
We can use even usually even when we do blepharotomy, we use a spacer graft, a donor sclera spacer
Yes,
graft to
it's possible.
create
It's
this
possible.
create the space. It
It's
gives
possible
so
also.
most of the
Okay.
cases, only the severe cases, I do a blepharotomy, and
Okay.
if in mild cases, especially it's with the blepharotomy, it's difficult to titrate, like I said. So in those cases, I do offer the patients HA fillers. Many of them are quite happy with just having
It's
a HA
possible.
filler and getting
Possible.
basically you add weight to the upper lid so that it
Possible.
equalizes.
But the thing is that
They're more worried about asymmetry.
but the thing that I don't agree with is tarsorrhaphy. Tarsorrhaphy will increase the intraorbital pressure, especially if the patient has got really some hard orbit. It will do the things, I mean, not the right way. I mean, like really tarsorrhaphy is like the ostrich, which put its head in the sand. I mean, like really, when you have a problem, you have to face it. I don't think lateral tarsorrhaphy will do. Okay, but
Oh, sir, I
blepharotomy is
just do
okay
it in mild cases, like
in mild
really
cases.
mild cases. Yeah.
Okay, agreed.
Although some, especially the proptosis is quite high, and I have seen patients who they have done lateral tarsorrhaphy, and there's a hooding on the side because it looks really bad, even cosmetically also. Even if they do a tarsorrhaphy in a patient who has prominent, like a significant proptosis, it causes a hooding on the lateral canthus.
Yes.
Dr. Mahmoud, I
Yes.
think we are
Okay.
okay with the
Okay,
time.
we are
But
okay
before
for-
we close, if you don't mind, we have just to select the winner for free registration for next MEOM. We have 3 winners today. For those they attend the meeting, so we can go to the selection. Abdullah.
Oh.
Okay, by the names. Okay. Okay, Muhammad Al-Mashhadani. I know Dr. Muhammad from Iraq. Dr. Muhammad, welcome. You are the first winner for free registration for MEOM 2026. Okay, next, Abdullah.
Lab. Good.
Oh, Dr. Hisham. Dr. Hisham, he is
Hada-
all the time free.
He is not, he is
Very
every
nice.
day. He is every day
He
there.
knows.
He is part of the MEOM. So anyway, he is already the second one, Dr. Hisham Hashimi. So Dr. Hashimi is
انت وفرت الجائزة هيك.
Oh, we are now get benefit. That's all. Okay, the third one.
Come.
GC Rocky. Okay, GC Rocky. I don't know. So we will contact. I hope that everyone hear his name to send an email to MEOM, MEOM5@meomacademy.com. So, and they will contact him to register him for the next year. Thank you very much, Dr. Mahmoud. Thank you, Dr. Jacob, Dr. Fitraj, and Dr. Aziz. Dr.
Thank you.
Thank you for all the speakers, Dr. Inji, Dr. Cobra, and Dr. Cheris. We hope to see you in another webinar and to see you, inshallah, also in the conference next year. Thank you very much and good night. Anything to say, please? Thank you.
Okay,
Thank
bye-bye.
you.
Thank you.
Bye.
Thank you.
Thank you. Thank you. Thank you.
Bye-bye.
Thank you very much.
Thank you. Thank you. Good night.
Bye-bye.
Night.
Thank you. Wassalam.
Yeah.